Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Okay, I think I see our speaker, and we can continue to do our introductions here in the chat. Um, so I'll give it to you, Dr. Chen.
Well, thank you. Again, I appreciate this opportunity to meet with your network. I did a little homework on what you're doing, and I think it's phenomenal. I had a chance to speak with someone else from Tennessee a while back. I can't remember who it was now, but I know that there was a connection made with the barbershop-based program out here in Los Angeles, and you all have probably been the first adopters and have been really remarkable at what you're doing for cardiovascular health in Tennessee. So I applaud you for that great work. Really an honor to talk about some of the things we're doing, and I'm here to learn. I'm here to learn about what you all are doing and how we can steal and borrow these ideas for Los Angeles. Hopefully some of what you hear is a bit novel. We're trying to leverage what we can do in our state of California. And as you know, every state has slightly different laws and regs and funding sources. So hopefully we get a chance to exchange some ideas that can work for our different territories. So I titled my presentation Community-Based CMM Targeting Cardiometabolic Conditions Supported by Value-Based Payments. Really trying to hit, I think, one of the key areas of need that we all have in this country as well as other countries, but really focus on that value-based aspect of this. So learning objectives, I think, are already spelled out for you. I don't need to read those over, but this is how I'm going to try to flow through this, give you a little background on the work we're doing in CMM, some of the foundational work that led up to it, some impact, and kind of what we're doing next with this work and the information that we have. This is preaching to the choir, so I'm not going to go over it in great detail, but it's an infographic that we created with the California Department of Public Health, just trying to make it really simple, the message of what happens when medications go wrong, right? The amount of money we spend, $528 billion, 16% of all healthcare costs, 3/4 of all hospital readmissions can be attributed to misuse of medications. That fourth leading cause of death in the US is probably an underestimate because I believe that's data from in hospitals. We really don't have good data from outside of hospitals. And then half of meds are not taken correctly each year. And I think for those of us that work, and I heard the introductions in this space, you see it all the time, that patients stop taking their medications. We had a really interesting series of focus groups here in Los Angeles from one of the nation's leading researchers on health disparities. And I got to sit in on them and participate. And it's really interesting to hear the different ethnic beliefs on medications. A very common one being, if I don't take medications, then I'm not sick. So the goal is to stop taking their medications, rely on supplements, other things that, some of them do something and many do harm, as we all know. So I like to share this with physician audiences. They know this all too well. I think it was almost 10 years ago now, there was a study that had come out that identified that it took about 17, 18 hours a day for a typical primary care doc to get all their work done. That study was updated twice, the latest in 2022. And as you can see here, it's more like 27 hours a day to get 24 hours worth of work done. And physician colleagues know this too well. You know this from those of you that are working with physicians closely. The fact is that team-based care involving a pharmacist and other care team members markedly reduces that to about 9 hours a day. Still not 8, but we're never going to get there, right? More than likely. This is an actual photo from a patient that we had worked with. This patient was in the LA County system, had about 4 different specialists, I think, working with this patient, and just wasn't getting to any of the chronic disease treatment goals. And finally, a pharmacist came in and started providing comprehensive medication management and convinced the patient to bring all her medications in. This is what she brought, almost 100 bottles of medications, half unopened. So obvious questions here, right? First question is, well, you told your physicians you were taking your medications. Why didn't you? The response was, I was afraid of the side effects. Okay, then why did you keep refilling your medications? The response was, well, I'm part of an auto refill pharmacy. So I share this with physician audiences in particular because I want them to understand that refill data is helpful, but it can be misleading. And I've worked with enough patients in my 25-year practice career to know that patients do funny things with medications, right? So this is about 56, with inflation, $60,000 worth of medications that were wasted, paid by taxpayer money. So just to level set, we all know the terms, but I'm in different audiences where we use CMM and MTM interchangeably. But let's just be clear that when we're talking about comprehensive medication management, we're talking about optimizing medication therapy, everything it takes to get that done. That means getting the right choice of medication given the broad array out there, not just drug class. We all know that there are particular agents in each class that have unique properties that can be better suited for a given patient, making sure the dose is not so low that it does nothing, not so high that it's toxic, ensuring that medications are safe given other comorbidities and other medications, making sure patients can use their devices. This is something that I see throughout my career. You teach a patient how to use an inhaler, bring them back in 6 to 8 weeks. They miss 2 or 3 key steps. It's inevitable. And then making sure the patients can afford their medications. All of this is wrapped around a collaborative practice agreement or arrangement with the physician's primary care provider, follow up until the patients reach treatment goals, and last piece is it's comprehensive, meaning it's all conditions, all medications. It's a little different from, I think, the traditional Medicare Medicare MTM mindset, which is a once-a-year check-in. I'm preaching to the choir, but this is what I have to remind physician audiences. And again, I also like to remind audiences that this is not new. Comprehensive medication management has been around for a while, just wasn't named that for the last 3 decades. And these are all non-physician organizations that endorse different aspects of pharmacist involvement in CMM. So, our journey in this direction, I've practiced for 25 years. I started in the VA. We were doing CMM back then. What do we call it back then? We called it pharmaceutical care, right? For those of you older than me or as old as me, you remember that term. And after those 10 years, I joined USC, worked at Cedars-Sinai, Beverly Hills, working with a completely different population. Spent about 5, 6 years there. I really enjoyed that work. And then ended up working on Skid Row for another 10 years. And that was really where I enjoyed the best practice of my career, just understanding the challenges that Americans face when they're in their most dire circumstances. So one of the things that we did during the time that we started working with safety net clinics back in, I think we started in 2004 or so, is we got a chance to work with HRSA on something called the Patient Safety and Clinical Pharmacy Services Collaborative. Some of you probably remember that. That was a great adventure because I got to learn what happened across the nation in terms of how pharmacists are utilized or underutilized. It was, as you could imagine back then, quite variable. And through that process, we were able to learn sort of what CMS's priorities were and had a chance to apply for the round one Center for Medicare, Medicaid Innovation, Healthcare Innovation Award, which we were able to secure. And in this program, we basically tested what happens when you integrate 10 clinical pharmacy teams into the largest private Medicaid provider in the nation, Ultimate Health Services, including one arm that was telehealth. This is, we're talking back in 2012 when telehealth was not very common. And the equipment was very, very expensive back then. Now we know it's not. And basically evaluating the impact on the quadruple measures. Oops. Okay, new computer, don't fail me now. Okay, good. All right, so we thought about this 3-year project, and first of all, realized 3 years is no time at all to get this done from start to finish. And so we tried to go after high cost, frequent flyers to the hospital type of patients and target those for enrollment. We also came up with an algorithm of 48 different triggers that identified patients that had gaps in medication-related quality or safety. We used demographics, medications, labs, problem lists, et cetera, vital signs. And examples are patients with reduced ejection heart failure that were not on key life-saving medications, patients with persistent asthma, not on controller meds, things like that. And our hope was that we could train the physicians to understand what it is that we were looking for, and that by helping these very challenging patients, it would help them as well. That worked really well. In the first, I think, within 2 or 3 months, the majority of our referrals shifted from the algorithm approach to the physicians handing off patients to us. And the majority of those patients were actually in those algorithms, so it was perfect. So we provided CMM to these patients. We kept seeing them until they reached their treatment goal. And even when they met their goal, for those of you that have been in AmCare long enough, you know that it's great to graduate patients, but you unplug the intervention, they come back, right? So we had our techs checking in every few months, really simple yes/no questions, tracking numbers that they should be monitoring. And if anything was in the wrong column or out of range, that would be routed back to the pharmacist for evaluation, and the patient would be re-enrolled. And through that process, we did indeed keep patients at control. So in this program, about 6,000 patients were enrolled, mostly Latino and mostly women. 3/4 had hypertension, 2/3 had diabetes. And interestingly, what we are a little disappointed to find was that the baseline rates of hospitalizations were on the lower side. So it wasn't an opportunity to show tremendous reductions in cost within a 3-year period, but we did see results that we thought were really helpful. I'm going to play this clip from the lead physician who's going to talk about the results of the program.
Hi, my name is Michael Hockman. I'm a primary care doctor at the University of Southern California. And when I finished my medical training in Boston, I had probably the view that many doctors have of clinical pharmacists, that they're folks who are working in retail settings, doing really important work, catching the mistakes that we make when we write something wrong for our patients. And it wasn't until I came out here and started getting exposed to new ways to provide team-based care to patients that I could see that this new role that pharmacists could play. And so in partnership with some of the pharmacy leaders at the University of Southern California, we got a grant from the Centers for Medicare and Medicaid to see what would happen if we could integrate pharmacists into the primary care team. So in the old model, the way it would work is I would have a patient with diabetes, and I would first talk with them about lifestyle changes. I might start them on a medication, another medication, add insulin to their therapy, and all this would take a lot of time. I'd have them come in for multiple visits. At the end of the 3 months, I could have seen them 5 or 6 or 7 times. And that model works, but the problem is that it's very time consuming, and it really prevents me from doing all the other things that I need to do as a doctor. So when we got this grant, we had a pharmacist right there on site with us who, with a collaborative practice agreement, could do this. And then the way it would work in this scenario is I would refer the patient to the pharmacist. Under that collaborative practice agreement, they would start the medications, do some of that lifestyle counseling, potentially add insulin therapy. And then the patient would come back to me 3 months later, and in many cases, the A1C was in much better shape than I would have been able to do on my own. So it was a tremendous pleaser for providers at this health system where we first implemented it. And ever since then, I've been just a huge advocate of what clinical pharmacists can do. And in a nutshell, this was one of those projects that really achieved the quadruple aim. It was, as I said, something that the staff, the providers, and the nurses, the medical assistants all immediately saw the value of. So it was, staff liked it. Patient satisfaction was extremely high. And I remember on one occasion getting called in by our chief executive officer, and he said, "Why is it, Dr. Hockman, that your pharmacists have higher patient satisfaction scores than all the doctors here do?" And I thought about it for a long time, and I actually think the reason is patients really like the ability to have someone get to the bottom of their problem. So when I'm seeing them for their diabetes, I'm also juggling the depression and the shoulder pain and all those other things that they're doing. And it takes a lot of time when you're doing so many different things to make progress. What I think patients really appreciated about the pharmacists is that they were able to focus on one problem, make progress, get to the bottom of it, and then they came back to me and we could deal with all those other things. So staff satisfaction, patient satisfaction. From a quality perspective, we found that pharmacists were 11% better than doctors at managing diabetes. They were 9% better than doctors at managing blood pressure. Again, there's probably a couple different reasons for that, but I think a lot of it had to do with having someone who was focused on the team on these chronic conditions who could get to the bottom of the problem. And then finally, in terms of cost, of course, it adds cost whenever you add a new member to the team, but we found that there was about a 10% reduction in ER and hospital costs. So if you're looking at it from a total cost of care perspective, certainly a lot of those upfront costs are going to come back to you in the form of reduced savings from costly ER and hospital visits. And of course, if you're in an environment where you're able to bill for pharmacists, that's beneficial. And in terms of quality scores, if you're doing 11% better in terms of your diabetes control, 9% better in terms of your blood pressure control, there's going to have some patient satisfaction benefits. So this is one of those few things that we have in healthcare where it really is a win across the board, across all those 4 quadruple aim pillars: staff satisfaction, patient satisfaction, quality, and total cost of care. And of course, the $1 million challenge with making this model work is the business case. Because quite simply, unfortunately, in many places in this country, pharmacists are not able to bill for their services. So the way to make a case for having a pharmacist on the team is if you're in a capitated environment where you have a fixed budget and you can say, we want to invest a certain percentage of that budget in pharmacists because we believe it's a high value service. And I think the evidence supporting that this clinical pharmacy services are a high value service is beyond reproach at this point. And I think in terms of an advocacy perspective, those full risk fixed budget environments aren't present everywhere. And so we need to keep advocating for policy changes so that pharmacists will be billable providers, which is something that will really benefit patients, healthcare providers, and the system as a whole.
So hopefully you understand why I share that video. I literally stopped him walking across the USC campus and said, hey, can you do a quick comment for us? That was one take. So he's a remarkable partner. He's gone on to do some great work in street medicine. But I thought he summarized the data very well, and he shared it from a physician perspective, which I think is so important when speaking to other physicians about the value of this work. We did have some data on mortality, which surprisingly did show a benefit with the intervention, given how short the intervention was in duration. It was small, so we're not going to make big news out of it, but we did see a statistically significant reduction in mortality in the patients that we served. Probably the backstory, which I think all of us know as pharmacists, is when you get asked that question, why would you plug in a pharmacist versus a nurse practitioner or a PA or other physician extender? And what I'd like to point out is, we're not actually physician extenders, right? We have a different skill set that's pretty unique on the healthcare team. And the way we quantify this is by tracking the medication-related problems we identify and resolve. So we have a process that we had developed when we were working with HRSA on that patient safety and clinical pharmacy services collaborative that lumps different interventions in different categories and tells a story. So in the story of the CMMI grant program, we had about roughly just under 6,000 patients that received an intervention, over 67,000 drug-related problems. That's over 11.5 per patient. That's a lot, right? And these are not just simple problems. If you look at the distribution, the majority of problems that we identified had to do with appropriateness and effectiveness of drug therapy. That means perhaps not suboptimal choice of drug, dose was not adequate or dose was too much. Even indications that weren't being treated were in this category. Now, granted, there was non-adherence, about 20% rate of identifying that. There were patients that were out drinking their water pill, out eating their diabetes meds. But we've collected this kind of data in the VA health system. I did it at Cedars-Sinai, I did it for Skid Row. It's always the same, right? Pharmacists in this space, when they're optimizing medications, most often intervene on drug therapy that is not adequate. So end of the day, we thought, boy, this program really hit it out of the park, hit all the quadrupling outcomes that Dr. Hockman shared with you, actually lowered mortality. CMS is going to now grant provider status. We proved it works, right? So naive. Of course, that didn't happen. The CMMI awards were all about startup. It was about proof of concept, and then we, the recipients, were supposed to figure out how do you roll this out and make it sustainable. So, one of the thoughts was, well, let's see how we can make this available to any health plan, any insurer that wants to do this. And one of the observations I had when I was working in Skid Row were very much scenes like this, where physicians would come into the hallway. It's really frustrating to see this patient because they just don't come back, right? And the other comment is that I get from patients when I see them, they're referred to me, is, yeah, I really like that physician, but what he or she tells me isn't going to work for me. And they explain why. So there's really a disconnect, right, between what the patients need in terms of access and what they need in terms of resources and assistance. So one of the really fortunate things, and I hinted at this earlier, that I got a chance to be a small part of, is the beginning of the barbershop-based intervention led by the late Dr. Ron Victor. He was from Texas, not too far from you, and closer to you than me. And he observed that, well, he did some research to figure out that the way to intercept the population that suffers the most from uncontrolled hypertension in terms of heart attacks and strokes is catch them where they already are, which is barbershops. And so he ran a small study you may be familiar with in Texas, where he trained, I think, about a dozen or so barbershops to screen patrons for high blood pressure. These are all serving Black patrons. And for anybody with BP above goal, they would be given NIH-approved information on the importance of managing their blood pressure. For half the barbershops, the barber would facilitate appointment with the patient's primary provider to get follow-up on the high blood pressure. And he thought, this is going to be easy. After 12 months, we're going to see dramatic differences in blood pressure. Well, as he puts it, this is a literal quote. He said, when I saw the results, I cried because there was really no difference between the two groups. And when he looked closer, he realized that even when patients made it back to see their physicians, and by the way, if they did go to see their physicians, they get a voucher for 6 months of free haircuts, so a lot of incentive built in. Even when they went back, there was no action in terms of the medication advancement. So when he came here to LA, I was introduced to him by Rita Shane. You might know her. She's the chief pharmacy officer, now vice president for Cedars-Sinai. And we met, and I said, have you thought about using a pharmacist? And he did his own homework, and he said, hey, Steve, there's scores of great research out there that shows pharmacists are better at managing blood pressure than other members of the healthcare team. So he was excited, and his concept was, if we add pharmacists to the mix in the barbershops, can we overcome physician inertia and get to the point where patients get better medical treatment? And I'll confess fully that I failed in my part. I did help him get the initial protocol in place, and I got some folks together to start the process. But my other piece of homework was I had to engage one chain drugstore in this program, and I tried, and we went all the way to corporate, and there wasn't one that was willing to do it. So his original idea was actually to have the patients identified in the barbershops and then sent to a chain pharmacy for the follow-up care. But since that fell apart, he ended up sending the pharmacist into the barbershops. His concern was that might disrupt the culture that's very positive in those barbershops, but it ended up being not true. In fact, they were very welcoming of the pharmacists in the barbershop. So what did they do? At least monthly appointments, actually more often than that in the beginning, more like every couple of weeks until blood pressure started to improve. They checked blood pressure. They had a CPA, a collaborative practice agreement, to modify drug therapy on behalf of their primary providers. They would monitor electrolytes using iStat. They'd send progress notes to the PCP, and really conveniently, we had an alum that owned a pharmacy in South LA. That pharmacy would deliver meds to the barbershop at cost. So it was really a phenomenal ecosystem that set this up. And the results sort of speak for themselves, right? Back then, the blood pressure target was 140 over 90. Got about 90% control of blood pressure in the intervention group versus 32% usual care. And before you think, well, the disparity was probably health insurance. 85%, I think, of both arms had health insurance. So that wasn't it. They were actually very well matched. In California, 1 in 4 people have Kaiser. 1 in 4 people in the study had Kaiser. So it was a pretty good representation of different patients. So, that was, one aha moment we had was that whole experience, which was fantastic. The other is things that we preach all the time, right? Pharmacies are everywhere. We've given over 300 million COVID vaccines through these pharmacies. I love using this analogy because people don't understand how many pharmacies are until I show them that there are 4 times more pharmacies than Starbucks out there. And in this study, that highlights that people show up in pharmacies a lot, right? If you're a non-senior Medicaid, you're in a pharmacy every 2 to 3 weeks, 2 to 3 times a month, actually. If you're a senior, at least once a month. So kind of like the barbershop, a lot of FaceTime. And by the way, I didn't know this, but patrons in Black barbershops get a haircut every 2 weeks. So again, a lot of frequent follow-up and FaceTime. So again, not trying to preach to the choir here, but accessibility, the hours of operation, already established high level of public trust, the fact that in most cases, if not the pharmacist, at least the pharmacy technician is culturally, linguistically aligned. We have this year, finally in California, a payment parity law that requires that pharmacists that provide this type of longitudinal care in partnership with health systems have to be paid like an NPP or physician would be. So we're in the process now of setting up what that looks like in partnership with all the health plans in California. And then probably the very important thing, as you know, for underserved populations is just that familiarity with local effective resources for social needs. All of these, I think, are so unique to community pharmacies. And when people ask me the question, well, why don't you just do this in an integrated health system? Well, again, I think these are selling points that you can't duplicate in an integrated health system. And the point that I want to really harp on, and you all know this well, is if we're not addressing the social needs of the patient, we're not addressing the biggest contribution to their overall health. And this is why we're super excited about launching a community health worker certification program for pharmacy technicians that can be used anywhere because we're now doing it remotely in terms of training. But the unique thing in California is that there's, as of 2022, there's legislation from the Department of Healthcare Services to fund over $200 million a year for CHW services. So now we have, this opportunity to, through community pharmacies, provide this benefit, have somebody in the pharmacy paid at the same rate as a pharmacy technician who's addressing care coordination, advanced education, preventative care services, and screening for social needs and connecting patients to resources, all off the books of the pharmacy. That's value, tremendous value. And then to add to that, you probably know this as well, the FQHCs, Federally Qualified Health Centers, prospective payment system does not allow for billing of CHWs. That means this is a great opportunity now for pharmacies to partner with FQHCs and provide these CHW benefits and create more opportunities for partnership. So, with all that in mind, we said, look, let's start something in community pharmacies, right? We call it the California Right Meds Collaborative. Our vision is that community pharmacies will become the health and social services hub in every neighborhood through a value-based process. The vision is simple. Health plans stratify patients from high to low risk. We identify not networks, but we identify pharmacies that are in a good position to provide comprehensive medication management in terms of their location, their layout, their processes, their staff, et cetera. We provide tremendous training, heavy training to these pharmacies to get them ready. The plans send those high-risk patients to these pharmacies, and we work with other pharmacy schools to make sure these teams are successful. So that probably starts with the vetting process, right? Maybe it's a bias, but I don't think every pharmacy can do this. We do vet them in terms of a questionnaire, a very exhaustive one, to identify whether they're prepared to do this kind of work. We do an on-site assessment. The health plan looks at the data they have on that pharmacy to make sure they're doing good work. They have to be obviously in a good location that makes sense. We've got pretty steady funding from the CDC, thanks to our partnership with LA County, to support much of the administration of this. As I mentioned to you before, the pharmacy technician is golden, not just because we're certifying them as community health workers, but even before that, back in the time that we had our CMMI program, we created a clinical pharmacy technician training program that would basically train pharm techs to do all those things that are part of a ambulatory care or CMM visit that you don't need a doctor or pharmacy for. So contacting patients, making first contacts, selling them on the program, doing the rooming, doing the vitals, doing the point of care if needed, helping to do follow-up appointments, helping with education since they speak the language so well, doing check-in phone calls, managing the patient assistance program. That's really high value. And we found that by having pharm techs do this, we were able to increase patient visit volume by 50%, 50. So again, tremendous value. One of the big challenges, of course, is we don't have HIE sharing here in California yet. It's in the works. So we've partnered with a company called ARENE to allow all the pharmacies in our collaborative to document on the same platform. And we use this for a very rigorous continuous quality improvement process and to report outcomes. As I said to you before, the value-based payment is key, right? When we approached the health plans about this idea, they're not crazy about paying anything for service or out of pocket. They don't have to. So we created a shared risk payment model where about half the payment comes in fee-for-service payments for a limited course of time or a limited number of visits, and the balance, about 50%, is only paid when the treatment goals are reached, established by the health plan. And then from the barbershop program, from other work we've done before, we're very familiar with using CQI to drive results. I think that's a really important aspect of this work. We have, like I said, we train our teams to death. We have 2 live learning sessions every year, full day learning sessions. We have monthly webinars. We have additional trainings that we provide one-on-one coaching. Much of it is based on what we see with the CQI report card. We see where the patient, where the pharmacy struggle, and we focus on that. But we also train on, how do you screen and manage social determinants? How do you provide culturally competent care? How do you increase patient engagement through motivational interviewing, shared decision making, and so on. And like I said, dashboards are really important. This is actually from Minnesota's Health Partners program, but very similar to what Dr. Victor did for his barbershop program, watching very closely progress as over time as patients were enrolled. This is also, again, from Health Partners in Minnesota. And I just love their graphics. That's why I'm sharing them with you. I think they very nicely showed how medication intensification occurred very early on in their intervention, and patients got to goal typically and most commonly within the first 3 months. And that's our experience as well when it comes to hypertension. We have many health plan partners, many public agency partners, many health organizations that are part of this collaborative that have been the key to spreading its successes and getting more interest in partnerships. In terms of just some impact, quick snapshots, LA Care Health Plan is our biggest partner by far. They insure over 2.5 million patients. This was our pilot with them, had about close to 20 pharmacies to start with, and as you can see, spread around LA County. We had each pharmacy paired with at least one FQHC. The idea there was we tried to facilitate as much referrals from the FQ as possible, and as a result, facilitate better communication between the pharmacy and the clinic. We would tell our teams, if you can, you should try to get into their monthly medical staff meetings, share what you're doing, the importance of it, share some results, and kind of get some rapport going so that eventually you can get the CPA signed, you can get sharing of EHRs and that kind of thing. So for LA Care and for any health plan, we always ask, what's your biggest pain point? And usually it's about cost, right? It's about things that drive admissions and readmissions. In their case, they said, we're really struggling with A1C, and it does factor into how we're paid. So they decided to pilot with patients with A1C above 9%. But the value-based payment required A1C at goal, BP at goal, and at goal meaning, at least for this one, at least less than 140/90, and the patients on statin if not contraindicated. So that first cohort, 500, 600 patients, about half, a little more than half, were from Antelope Valley and South LA. These are very well-recognized medical desert areas in LA County. Over a quarter self-identified as Black, and that was all intentful. LA Care has not nearly that percentage of patients that are Black, but they wanted to focus on the Black community because of the challenges they've had with getting adequate quality health care. And these results are actually shared on the CDC's Field Notes page. If you go to CDC Field Notes USC Pharmacy, you'll see it there. The average A1C drop for patients that made it to 5 visits was 3.3 points, systolic blood pressure reduction of 34 points, and almost 90% of members with diabetes were on statin, compared to 42% at baseline. So the short of it is, LA Care loved it. They moved this from a pilot to a full program. We're now in the process of trying to expand into any patients who are discharged from a hospital with a cardiovascular disease or stroke diagnosis. With another health plan, Inland Empire Health Plan, we piloted with asthma. Again, that was their choice. They had lots of admissions for asthma. The skinny of it is with about 70, 80 patients that we piloted this with compared to over 700 usual care patients. In the right-hand pane, you can see that on the very far right, 6 months after the intervention, there were 0 hospitalizations for asthma. In the usual care group, you saw a doubling. So a very powerful impact from this focus as well. So if I have time, Ashley, I'm going to wrap up with this video, and I'll cut it short, okay, if you tell me to. All right, thank you. This is a testimonial from a patient.
Hello, everybody. As Doc Chen said, I'm Mike Metcalf, and I just want to tell you a little bit about how we met, the struggles I was going through, and how USC Clinical Service pharmacists, Dr. Chen, and students changed my life. Sometimes I get a little emotional because I credited Dr. Chen for saving my life, because I came off of Skid Row. And down there, I was just a statistic or number. All the doctors did, and they deemed me as a troublemaker because I wanted to know what it took to live life on life's terms. I was 301 pounds. I'd eat 2 big giant pizzas. Now my waist so skinny I could hula hoop through a Cheerio. I had to put holes in my belt to keep my britches up. My stomach was so big, I couldn't look down and see my feet, and I weigh 11 and a half. Follow me closely. The doctors, I was going through an unfortunate experience at that time in my life, and it led me to find shelter for free on Skid Row. I don't think no one should find out how I found out I became a diabetic. I woke up 8 days later, I went into a diabetic coma. I woke up 8 days later and didn't know where I was. I'm on the eighth floor in the diabetic ward of General Hospital. They had me tied to the bed because they said I was fighting people. I didn't have a clue where I was. But getting back to the story and the topic, I was deemed a trouble patient. Why? Because I asked doctors, what's this for? What about my A1Cs? How would I test this? Can you answer why I got to take insulin? I'm scared of needles. They would push the button, call security, and put me out, or send me home. They told Dr. Chen I was a troublemaker. Thank God for University Southern California Clinical Services, because Dr. Chen showed up with his pharmacy students, and it was a wedding in heaven right here on earth. Dr. Chen listened to me. He answered my questions. He gave me hope. He taught me how to count my carbs. He taught me to watch what I eat. He told me I shouldn't have to live to eat, but eat to live. So I got interested. I grew me an organic garden. I got greens, cabbage, garlic cloves, bell pepper, onions. When I tell you my waist is so skinny I can hula hoop through a Cheerio, I mean it. From here to here, Dr. Chen gave me hope. He listened to me. He helped me. He told me what to do. And my thing is, everybody under the sound of my voice that have anything to say or do with helping getting more pharmacists and pharmacy students in the clinics all over the world, please do it. Because other poor people, God has blessed me to come out of my situation. Not only my life being saved through Dr. Chen and the pharmacy students, but my situation at whole. I'm really blessed. But there are people that's dealing in situation with doctors that all they are is a statistic and a number. All they want to do is get you in and get you out. They don't tell you what to do to live. They don't tell you how to take your medicine. This is kind of cute. I was on insulin for 3.5 years. I mean, I'm scared of needles. I'm shooting this needle in my stomach, but I'm thinking in the back of my mind, this is for my life. I said, Dr. Chen, how long I got to shoot this insulin? He said, for the rest of your life. I said under my breath, shit. Not me. Right then, at that second, I took a hold of myself and I said, I want to live. I'm not going to stick myself for the rest of my life. I started paying close attention. I started learning. I started exercising. I stopped eating bread for a while, cut out pizza, started replacing that with salads, go to my garden, work my butt off. It was making me sweat. I started doing all the right things. And I give that brother right there credit, because Dr. Chin taught me how to live with this disease called diabetes. And not only do I share it with you guys, I share it with everybody I come in common with, my friends, people that's less fortunate. And I just want to say thank you very much to the University of Southern California Clinical Services, because y'all give people hope. And that's all.
So I hope you know why I shared that. He's such a powerful story. He taught me a lot more than I taught him, and he didn't even give the punchline. He got off of his insulin successfully. So just amazing story. So I know I'm out of time. Bottom line is, the work that we're doing has something for everybody: patients, frontline providers, people who pay for healthcare, whether you're talking about total healthcare cost, satisfaction, quality of care, patient safety. Lots going on. As I mentioned before, we have 2 learning sessions every year. One is physical health focused. The other one is mental health and substance use focused. One in spring, one in fall. The spring one, in fact, is coming up in 2 weeks on a Sunday. A Sunday because community pharmacies can only free themselves on that day. Then it's all virtual. So I don't have time to cover everything else, but just, we have something in Hawaii. We have a Hawaii first annual Applies Conference, Advancing Pharmacy Practice, Leveraging Innovation, Equity, and Safety. They'll take place October 21 and 24. It'll have some international attendees as well. So if you're interested, this is the information. And that is it. Love to hear any questions you have. I put some up here in case you wanted a few prompters, but welcome any questions. Thank you.
Yeah, let's go ahead and take some questions from the group, and I will share the information for how to earn your CE credit from today.
Oh, sorry. I didn't post that. My apologies.
No, that's okay. Let me make sure I can share my screen. Go ahead. Anybody that has questions, go ahead and unmute. I know a few of us were texting about questions and comments as we were going through, and I see some in the chat.
Hey, this is Nicole. I messaged. We are actually thinking about implementing clinical pharmacy technicians in our own clinics. It's a discussion we've been having for several months now. What was the number 1 or 2 things that you guys struggled with as far as actually getting those technicians into place? Was there any training barriers or anything like that you had to cope with?
I would say there was not. I was really impressed. I don't think I was surprised, but I was very impressed with how excited the techs were to do this, right? The techs that participated, they've been interviewed in other articles, and their take is, this gives us an opportunity to meaningfully give back to our community in a way that we never imagined we could as a pharmacy technician. So certainly no lack of motivation on the part of the pharm techs. Maybe the only challenge that we see, because we continue to do this on a regular basis, is just trying to free them up from their work, right, to do this. Sometimes we have to do it, during odd hours. The pharmacies have to pay them still, right? So that's probably the only challenge, is the pharmacy's willingness to pay them while they're getting trained. Again, we've converted this to pretty much all virtual at this point, so they can do it remotely. But even having said that, remember, we're trying to teach them some basic skills, vital signs, point of care, some motivational interviewing, things like that. So that needs to be observed. So maybe the technical aspect of it is to make sure that you're able to provide enough proctoring, even remotely, to be able to observe these skills that are important to fulfill this function.
I have a question. He talked about his organic gardening and nutrition. Were there other players? Did you teach him how to organic garden, or did you? Were there other players there? What did that look like? And was there a nutritionist involved as well?
A great question. So the homeless clinic that I worked at, called Center for Community Health, had a nutritionist for a short time and then lost it. So I'm not a nutritionist, but I did the best I could, right? So I did teach him to count carbs. I did teach him that you can't eat 2 pizzas a night for dinner. There's always low-hanging fruit, or often is, for patients with
Right.
diabetes, right? So I nipped that pretty easily, but he's the one. This is where I'm not kidding when I tell you he taught me a lot. He's the one that did his own research, and I went to see the garden. It was back when I didn't have a cell phone with me, unfortunately, but it's a remarkable plot of large land, and no, he's the one that did that. He literally ate off of it. I think he had an aunt that was a nutritionist, so that helped a little bit.
Oh,
But he dramatically changed his diet and, yeah, lost, as you said, what do you say, 30, 40 pounds? Can't remember what it is now. But yeah, I don't take credit for that part of it. He really ran with it.
I have one more question in light of that. Did he have any mental health issues that had to be worked through
Good.
with that as well?
Yeah, in his case, no. He was, boy, the stories that you hear in Skid Row, they're heartbreaking. He was one class away from getting his bachelor's degree. And
Mm.
things happen, life happened, right? Bad things happened, and he just could never go back to school. He's a very smart man. So no, the short answer is no. Yes, we had plenty. We had plenty with comorbid schizophrenia, comorbid depression, everything else. At the time I worked on Skid Row, we had a psych pharmacist there a day a week, which was fantastic, right?
Mhm.
But no, in his case, he did not.
Thank you.
Thank you.
Does anybody else have questions?
Hey, Steve. I think we met at the Alliance
Yeah.
Summit, didn't we?
Yes. Good to see you.
It's good to see you, man. And as much as I enjoy getting to learn about you at the conference, it's really cool to see this presentation. And kudos for capturing the physician support and patient support. I know a lot of pharmacists who have stories like that, but I think just a thousand kudos to you, man, for capturing it really well in a really persuasive format you can share with others. So that's kind of a comment, but a question, if I can ask a question. I'm working on I'm actually working with Nathan Kainer.
Yeah,
You know him from
I know Nathan. Yes.
So we're doing with actually a fairly large author group a review of all payment parity and state-based reimbursement laws. And so we actually got to learn. I got to learn about AB 317 this past month.
Yes.
What you mentioned a little bit, but I was just wondering if you expand on how you anticipate that working in some of the community pharmacy models that you're looking forward to. I don't know if you might also comment on just the fact that it doesn't seem like it applies to Medi-Cal. That was kind of a bummer from learning about that, but it didn't apply to all state Medicaid, or at least my understanding is that it didn't.
Okay, great. Yeah, great questions. First of all, I want to clarify that Dr. Hockman, Mike Metcalf, they are just remarkable speakers on their own. So all I had to do was turn on the mic and let them talk. And I was lucky that they're so good at it, right? So yeah, what a great question. 317 was and still continues to be a bit of a challenge in many ways. We literally met yesterday with all the health plans in California to talk about implementation. And I'll tell you that they're all challenged tremendously. They have different understandings on what the law means and how to apply it. A good example, HMO patients, are they even included in this? It's really unclear. Where is it headed? I asked that very question, Jonathan, about whether or not there are restrictions, meaning, so our Medicare plans, are they not included, Medi-Cal not included? And the take by the California Associated Health Plans is no, they are included. If you look at the way the legislation is written, it doesn't say they're excluded. So I was same expression you had, I had. I thought, oh, really? So we're still trying to further that to make sure that's the case. But boy, that's exciting, right? To be able to say, hey, managed Medi-Cal, you guys need to be players in this. The good news is as well that every managed Medi-Cal plan is a part of the California Associated Health Plan. So they were on the call, they heard that comment. So that's where we're headed at the moment. What are the implementation barriers? Credentialing is daunting to the plans. They're thinking, okay, we have to individually credential all these pharmacists. We don't have the resources for it. That's going to be a challenge number one. The second is the billing part. I already mentioned to you the HMO population. Do they apply? Do they not? A really funny insertion in the language of the bill is there's mention that you must pay if the patient sees an in-network pharmacy. or they can go to an out-of-network pharmacy if the plan has an out-of-network pharmacy benefit. And so the plans are asking, what does that mean? Even the lawyers don't know what it means, right? So there's a little struggle there. I think they still are not sure how it applies to HMO patients at the moment, but they're trying to figure that out. And then the other aspect of it is this medical billing or is it pharmacy billing? Is it going to be billed through a PBM? Is it going to be billed on the medical side? The pharmacies are thinking PBM billing is easy. We can do that. Right? Medical billing is hard. We don't normally do that. But as you're probably shaking your head and thinking, if this is a true payment parity law, it's a medical benefit. It's a medical bucket issue, and pharmacies are going to have to start billing medical. So that's kind of a quick summary of some of the highlights yesterday that we talked about.
Yeah, that's a great call out and reminder that I forgot about when I started speaking, but it's also restricted to just pharmacies. And I was curious why, and you may not know this, may not be appropriate for our conversation here, but hopefully we'll see that also go to the pharmacists as well.
Yeah. The restriction to pharmacies was not intended. When the bill was put out by Akila Weber, the assemblywoman out of San Diego, it was intended to be for all pharmacies working in outpatient environments. And as bills go, it got routed to a group that I think was representing retail chain pharmacy, and they inserted it and it stuck. And interestingly, the plans that were represented during California Pharmacists Association's lobbying said, we like that actually. We like to keep it in there. So, it's a foot in the door, more like a leg in the door, right? It's actually not bad. And as I said, I think there are many points we can leverage to make this work really well because of some of the circumstances unique to California. And hopefully we eventually get it into the integrated practice environment.
Thanks for our manuscript ends up being accurate with regard to coverage of Medi-Cal or something. If you can get me and Nathan something in writing, we'll make sure we correct the manuscript.
Okay, awesome. Well, let's keep in touch. So I'll keep you posted. This evolves. Okay, thanks.
Thank you so much, Dr. Chen, for your presentation. I know I have tons of comments over here in the chat saying that they have really enjoyed it. And so this will be posted on our webinars page under the resources tab for those of you to share with other pharmacists or other people in your team who would like to know more about what they're doing in California that can help us. And we really appreciate your time. We appreciate all of you for being here today. So thanks so much.
Thanks for having me. Have a great day, everybody.
Thanks so much. Bye-bye.
Bye-bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.